and welcome to Session 3 of the National Dialogues on Behavioral Health Conference, Special Populations, Persons with Serious Mental Illness and Persons with Substance Use Disorders. My name is Jessica Flick, and I'd like to introduce your host for today, Vijay Ganju, the President of the National Dialogues on Behavioral Health. Vijay, over to you.
Okay, Jessica, thank you very, very much. Well, welcome back, everyone, for those of you that were able to attend one of the prior sessions, and welcome to any of the new folks who've never had a chance to attend the prior sessions. My name, as Jessica said, is Vijay Ganju, and this year I am the current president of the National Dialogues on Behavioral Health. And on behalf of the Executive Committee, it's a great pleasure to welcome you all to this session. As you know, the title of the conference this year is Behavioral Health in the 21st Century, Fast Forward After the Pandemic. You know, the concept of this, of the conference this year is pretty simple. You know, we were on a trajectory where we were doing a lot of great things in different areas, and then all of a sudden COVID hit, and we had to scramble, and we had to essentially adjust and make all kinds of innovations and changes to adapt to new conditions. And actually on that track, it was a very fast learning curve for all of us. But that learning curve built on top of all the good stuff that was going on in the past is really the building block for the future. And that's really what our entire conference is about. We've had broad sessions, and I think as some of you saw in the last session that we attended, the focus was on crisis services. This session is going to focus on two populations, persons with serious mental illness and persons with substance use disorders. And then next week, we're going to focus on a couple of more special populations, children and adolescents, and persons who are part of racial and ethnic minorities. So we're going to look at those populations next week. And so we're looking at different cuts on what that future might look like for different services and for different populations. What I'm going to do is quickly go over some housekeeping things related to the session and the conference. And then I'm going to turn it over to Jan Kosovsky, who's going to be the moderator for this session. And she is currently the vice president at Access Health Louisiana, vice president for behavioral health services. And she's been a long-term member of the National Dialogues Executive Committee. So, okay, to business. So, Jessica, can I have the first slide? We can go to the next one. And, you know, I think I've gone over this, so I'm not going to dwell on this very much, but basically the National Dialogues on Behavioral Health is the oldest behavioral health conference in the United States. This is its 62nd year. It's a very unique conference because we focus on specific topics that the field is trying to grapple with at that time. And so in that sense, it's a very cutting edge conference. It's also generally in person in New Orleans. So it's also, besides being unique and cutting edge, it's a fun conference. And so, you know, I think as one person said in an evaluation a couple of years ago, it's really sometimes recognized as the jewel of behavioral health conferences. So just want to underline that factor and hope we can see a lot of you in person next year in New Orleans. Next slide, please, Jessica. And so I'm not going to go over this, but this gives you a sense of the range of topics that we've covered in previous conferences. We've looked at criminalization of persons with mental illness. We've looked at the whole issue of reinventing the behavioral health workforce, looked at how you promote individual, family, and community mental health and resilience. We've had a whole session on how you create value, how you measure value, in looking at outcomes from different kinds of angles. Last year, our focus was on crisis response at state and local level. So just gives you a slight feel. I mean, I haven't got all the topics for the last 60 years, but just give you some sense of and feel for what we cover. And next slide, please, Jessica. And so, you know, generally when we have an in-person conference, we also have a pre-conference, and those are full-day sessions on a particular topic, and this will give you an idea of those kinds of topics that we cover: school mental health, how artificial intelligence is being used in behavioral health, you know, some of the stuff related to resilience and mindfulness and alternative medicine. And so just, you know, but that's like an in-depth investigation and coverage of these specific topics that goes even beyond what we cover in the individual sessions at the conference proper itself. Next slide, please. And so I've gone over this, but we have, these are the names of everybody on the executive committee right now. And as you can see, we're spread all over the country, and many are long serving. And, you know, so, you know, we've essentially, and it's really the work of this executive committee that results in the choice of topic and the choice of speakers that then become part of the conference. Next slide, please. And just want you to be aware that while we are the National Dialogues, we also have several conference partners, including the National Association of County Behavioral Health and Developmental Disability Directors, the Western Interstate Commission for Higher Education, and the National Association of Mental Health Program Directors. Next slide. And this year we have several organizations that have also been sponsors, and they provide us with some funding that sort of undercuts some of the costs that we incur. But just to underline the fact, we are a completely voluntary organization, and none of the members of the executive committee get any funding for the work that they do. But the three sponsors this year are Access Health Louisiana, Benchmark Human Services, and Genoa Healthcare. Next slide, please. And just quickly, I think, you know, I think as some of you who have attended the prior sessions already know, please use the Q&A function that's at the bottom of your screen to ask questions or make comments. Please include your name and state. And, you know, I'll just talk in a moment about how you can get CEUs. If people want to use closed captioning, you can, that's also available, and you have to turn on the subtitle function that's at the bottom of the screen. And then please, 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 and I'm going to say that again, please, 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 complete the online evaluation that, and a link to that was in the letter that you all should have received, but it will also come up on the screen after this entire session is over. And if you click on that screen, it'll take you straight to the evaluation. And next slide, please. And I just want to emphasize that there are two evaluations. One is an evaluation you have to do to get CEUs. And then there's another evaluation, which is the more general evaluation of the session itself. CEUs are available, and I think, again, as you've seen in the email that I sent to you, if you you need to register for the CEUs, and if you haven't, please send an email to Melanie Norwood at the address that is shown, melnor64@yahoo.com. And then at the end of the session, you will be provided a unique code word. And that is the code word that you will provide when you submit your CEU evaluation. And unless Melanie gets both the code word and the evaluation, you cannot get CEU credit. So just want to be clear about that. Next slide, please. And so again, for those of you that want to note it, the URL for the evaluation of the session is what is provided out here. https://surveymonkey.com/r and then 72ZYBV7. Okay, so I will end my session and turn it over to Jan. Thank you, Jan. Jan will be moderating the session and introducing the speakers. Thank you, everyone.
Hi, good afternoon, everyone. I want to welcome our speakers and our participants to our third webinar series. And I'll just tell you a little bit about the format. I'm going to introduce each of the three speakers at one time, and then each of them will go for about 25 minutes. The first speaker will be Mr. Martone, then will be Ms. Helfand, and then Dr. Podesta. So I did want to just take a moment and just say hello to my friends from Capital Area Human Services and Access Health. Good to see you all here. Mr. Martone has had about 30 years of experience in public mental health. He is the executive director of the Technical Assistance Collaborative, and he is the president-elect of the National Association of Rural Mental Health. Previous roles include the Mental Health Commissioner for the state of New Jersey. That's a really big job. And president of the National Association of State Mental Health Program Directors and CEO of a supportive housing agency. He is a national expert in mental health policy, administration, systems design, financing, and focuses much of his work on the intersection of behavioral health, community integration, and homelessness. And we all know those are three really important areas for people that struggle with mental health and mental illness on an ongoing basis. I'm very much looking forward to hearing his presentation. I want to go ahead also and introduce Ms. Helfand. She's received her PhD in psychology with a doctoral minor in statistics from Baylor University before she moved to Colorado as a postdoctoral fellow in the University of Colorado's Institute for Behavioral Genetics. She worked for WICHE Behavioral Health Program Team for Scientific Knowledge and Expertise. Did I just get that wrong? I did just get that wrong. She worked for WICHE Behavioral Health Program Team for Scientific Knowledge and Expertise. I'm sorry, I'm having trouble with that. And she conducted a variety of research projects and oversaw teams of evidence-based practice fidelity reviewers in several states. Before Rebecca worked for the Office of Behavioral Health in the state of Colorado Department of Human Services with the Office of Behavioral Health, and she worked on a variety of projects with other state agencies. Rebecca served as the director of the Data and Evaluation Unit within the Office of Behavioral Health. And she supervised a team of 12 people, which gave her the opportunity to work on a variety of projects throughout the Office of Behavioral Health. Sorry, Rebecca, I owe you on that one. Now, Dr. Podesta will do a better job. Dr. Arwyn Podesta is our third speaker. She practices here locally in New Orleans. She's a board-certified adult psychiatrist with subspecializations in addiction medicine, forensic psychiatry, and integrative medicine. After she finished her residency at LSU and a forensic fellowship at Tulane, she served as the medical director of the largest public addiction treatment center in the Gulf South. She's also been the medical director of multiple residential and intensive outpatient addiction treatment centers. She opened Podesta Psychiatry, LLC in 2020 with a team of some of the best treatment providers in the New Orleans area. They offer a multidisciplinary collaborative model with nutrition, psychotherapy, acupuncture, and psychiatry. She has been voted into the ranks of New Orleans Magazine's top doctors on an annual basis. Dr. Podesta maintains an active role in the academic community as a clinical faculty for a Tulane Psychiatry residency and Tulane Addiction Medicine Fellowship. She's a consultant to criminal court in reentry services and worked in New Orleans drug court for many years. In 2019, she was awarded the honor of Distinguished Fellow of the American Psychiatric Association, and she's an advisor for the Alliance for Benzodiazepine Best Practices. I did want to make a little plug is that she recently completed an update of her book, Hooked, and she is also a renowned speaker. regularly traveling to teach and speak on the topics of addiction medicine and integrative psychiatry. So I am very pleased to welcome the three speakers and our participants. These are topics that are very near and dear to my heart. I've been working with from more of a policy and administrative bend for quite a while now, and we'll go ahead and get started. So Mr. Martone, please go ahead.
All right, hopefully everybody can see that, and we'll get started. So thanks for having me today to speak at this panel. It's good to look at the participant list and recognize lots of names, familiar names. It's hard to say faces because the environment we're in, but it's good to see people who are participating. So I'm going to talk a little bit at a higher level just to give some perspective of what's going on and what we're seeing during the pandemic. And we'll drill down, I think, over the course of the entire session with all the other panelists too. So I think one of the things at the outset I think is important just to share at a very high level is just a couple of things to keep in mind. You know, what is the impact of COVID itself, particularly on people with serious mental illness who are actually contracting the virus? You know, what impact is that having to them, not only physically, but psychologically and psychiatrically, and what does that look like? What may that look like going forward? And I think that's something for us to think about, not only while we're navigating the pandemic, but as we maybe emerge from it. Social isolation component, right? I mean, this is a public health crisis that we're all experiencing. We're all experiencing social isolation to some degree or another. And maybe it's subsided in the last several months. Maybe it's still very impactful in particular parts of the country right now. But just trying to have a perspective for people with serious mental illness or substance use disorders who have been experiencing, you know, different types of isolation throughout the pandemic and what ultimately that may mean. And then broadly, the economic impact, not only to individuals with serious mental illness and substance use disorders themselves. For instance, if they were working and they had to be put out of work temporarily because of the pandemic as businesses closed, but also just globally thinking about the economic impact to all of us and what that means, you know, particularly if you're a person with serious mental illness who is, you know, living alone. You have to go to the food store just like everybody else, but you don't have a lot of money, you don't have access to transportation, you go to the food store, can't buy toilet paper, right? It's like all these different things that there's this trickle down impact of the economic crisis that we have experienced and are just trying to come out of now that will have impacts on the people that we serve. And I think those are just perspectives for us to keep, you know, throughout the session as we go forward today. So just some background data. I think one of the challenges that we're seeing right now is we're all living through this now. And a lot of the data that we're seeing is anecdotal. Some of it's based on surveys. Some of it's emerging. You know, we may not know the full impacts of a lot of these things for several years. And there are probably lots of data points that we're not even taking a look at right now. But here's some thoughts on what we do know and what we're seeing. You know, certainly I think we can all relate to that people in general are experiencing, you know, the mental health effects of the crisis. So not only just people with serious mental illness who had a pre-existing condition, but we know the general public is experiencing more mental health related concerns. And surveys have shown, you know, that upwards of 40% of adults or even more are reporting struggling with mental health or substance use since the pandemic began. And those findings, you know, have been sustained through the pandemic, and if anything, maybe have increased a little bit. Also with increased reporting of unmet mental health needs throughout the pandemic. I think we've also been seeing that mental health conditions are disproportionately affecting specific populations, particularly young adults, Hispanic and Latinx persons, Black persons, essential workers, unpaid caregivers. I mean, you can think about it and how it's impacted not only people themselves, but all the providers and the ability to provide services. What we've seen is overall, those with a psychiatric disorder reported more frequent mental distress and more recent missed medical visits and medications than people without a psychiatric disorder. But participants with serious mental illness did not report a higher rate of suicidal thoughts compared with pre-pandemic responses. So there might be a silver lining there, although I don't know that we're there and able to say that yet. I mean, if you look at you know, previous, you know, going back to the 1918 flu or other types of disasters or national disasters, we see, you know, long-term impacts coming from those, and we're still living this right now. Some of the data has suggested that suicidal ideation has increased, but we're generally seeing declines or suicide rates being about the same, during the pandemic. The problem is suicide rates were very high going into the pandemic. So, there's maybe a little bit of a silver lining there. That said, there are pockets of areas where we think we're seeing more suicides. In some areas, there was some reporting coming out of Oklahoma seeing a higher suicide rate. Also, particularly within the Black and African American populations, we may be seeing some signs of increased suicide rates. So, these are things that we're going to have to really dig deeper in and watch as we go forward. We also saw that emergency room visits for suspected suicide attempts among girls between the ages of 12 and 17 increased by about 26% during the summer of 2020, and by about 50% during the winter of 2021 as compared to 2019. So again, these are things that we'll have to really monitor as we're going forward. That's the emergency department data right there. We also saw some data that indicates that people with serious mental illness, and for that matter, maybe people with other disabilities, are more likely to contract COVID-19. And you can imagine that people, have more complex health conditions, underlying health conditions, maybe more medically frail or fragile, maybe living in, congregate or group or substandard settings with poorer personal hygiene and those types of environments. And so that's not necessarily surprising information. We also saw drug overdoses increase significantly in the past year, going back to 2020, 30%, and even more so now. And roughly 20% of people increased their substance use starting with the pandemic. We also saw, 34% of people in one survey experiencing changes in treatment or recovery support services for substance use disorders due to the pandemic, and 14% or so in one study were unable to access needed services due to COVID in general. We know that access to care in the workforce have been strained. Providers are strained and drained. Access to PPE was a major challenge early on, and it's probably still, much less so now, but even in some areas it might be somewhat of a challenge. But early on, I was speaking with various providers that I had contacts with throughout the country, and just the challenges there in accessing PPE was just unbelievable. And it was funny because I remember talking to one provider, and she was saying that they were literally buying PPE on the black market. And then it was at a conference session that Becky and I were on yesterday for the National Association for Rural Mental Health. We heard another individual from another state talking about having to buy PPE on the black market. So really, really troublesome for providers. We know that access to care was inequitable prior to the pandemic, and it even became more difficult during the pandemic. And so we're talking about, access on, when you look at health equity and health disparities, and particularly racial equity and racial disparities, access has been inequitable, and we think that has gotten even more challenging during the pandemic. Certainly workforce shortages have been exacerbated during it. There was a sudden withdrawal of an already limited mental health and primary care workforce, particularly in rural communities, but in all communities. And if you talk to providers during that period of time, the stories that they were sharing were just really, really challenging in terms of their ability to staff their agencies. We saw whole agencies close. We saw agencies have to scale back services, particularly on-site services. We saw, executive directors going out and providing face-to-face visits with consumers because, half of their staff were quarantined or at home taking care of people who were quarantined or sick, or they themselves were sick. So it really paints a picture of the challenges that the mental health provider community went through during this period of time. It certainly led to a massive natural experiment in the rapid and widespread implementation of telebehavioral healthcare. And that's something that we'll talk a little bit more about in a second, but is an area that we were, as a system, we were slowly creeping towards, and suddenly the light switch had to get flicked on to implement this type of service. And it will be interesting to see, I'll get to the slide in a second that talks about at least some of the preliminary data, but ultimately the long-term implications of how telehealth may or may not be used. We also saw, though, increased regulatory flexibility for medication-assisted treatment for substance use disorders, which was a really important counterbalance to some of the significant workforce challenges that we saw. So I'm going to hit a couple of different settings and provide some context here. And individuals with serious mental illness who were in inpatient, other congregate residential settings, nursing homes, group homes, board and care homes, were significantly impacted by the pandemic. And we're still seeing that to some degree. Individuals in these settings were less likely to transition back to community-based settings, particularly at the height of the pandemic. A couple of reasons for that include the belief by professionals that they'd be safer in the facilities and that the community provider system was too compromised to facilitate transitions. But what we also saw was the crisis there. And if you saw this play out in the news in many different states across different types of facilities, it was probably most glaring in nursing homes. But about 8% of people who lived in United States long-term care facilities died from COVID-19. It's about nearly 1 in 12 people. For nursing homes alone, that figure was 1 in 10. When you look at the number of people in nursing homes who have a diagnosable mental illness ranging from something maybe more mild up through a serious mental illness, 65 to 91% of those folks have a mental disorder. And you could think about then the disproportionate impact of people who were either got COVID, or even died of COVID in these types of settings. Very, very significant, and it's something that should not be lost on the system as we go forward and come out of this. We also saw early in the pandemic, many local acute care hospitals had to convert acute care psychiatric units from double to single rooms just to make sure they were maintaining social distancing. There were concerns about accepting patients exposed or with COVID. Access to PPE was an issue. And it certainly created additional challenges for emergency room boarding, which is prior to the pandemic was also a big issue in many states. This was similar in group home type of settings in states across the country too, where maybe you had a 10-person group home that had there were 5 2-bedroom units, and for social distancing they may have tried to move those to single room use, which fundamentally reduce the overall capacity of those residential settings across the country, at least for a period of time. Community-based services in general. So we also know during the time that many day treatment and psychosocial rehab programs had to close or dramatically downsize capacity for extended periods of time. We even see pockets of that going on now. Outreach and mobile-based services like assertive community treatment, permanent supportive housing teams also had to scale back face-to-face visits. Many shifted to virtual types of engagements with limited face-to-face as PPE became available. That looked like, maybe clinicians and paraprofessionals were not going into apartments, for instance, but they were maybe seeing people at the door, meeting them in the park, in places where, there was less potential exposure to the illness. Over time, though, as PPE, was more accessible, and certainly as we got into, vaccinations, we've definitely seen providers return to more of those face-to-face visits with folks. You also saw those providers at the time, balance, using new telehealth strategies to engage consumers with the face-to-face. One of the things too that, we don't often talk about employment for people with serious mental illness, and the numbers tend to be low, but for people who were working, as many businesses had to close or lay off folks and things like that, people with serious mental illness would have been impacted by that. And that's something I think that we'll have to really take a look at as we go forward. And mobile crisis response teams, where they did exist in communities across the country, certainly initially faced some of those same issues that ACT and PSH teams had, where they had access to PPE issues, they had a struggle with workforce, their own staff were getting sick, and they had to scale back some of those services. And most of that, I think, for a large degree, has responded and rebounded at this time. Telehealth, certainly, we know was a huge shift for the field. Systems rapidly shifted to using telehealth services. But what was needed to really and make sure that happened were legal and regulatory flexibilities that were enacted by federal government and state agencies so that these services could be provided not only through visually, but just on audio only calls. It's some interesting data though here. One study analyzed half of all private insurance claims between February 20 and April of 20, found a 2,900% increase in mental health telehealth claims. Another study examined a national sample of commercial and Medicare claims between January 20, or from January to June 2020, I'm sorry, that accounted for almost 57% of total psychiatry visits, 51% of social work visits, 49% of psychology visits during the period. In general, and particularly in rural areas, I think you can imagine, telehealth offers a more convenient way for people to access mental health services. And it's certainly also, given our workforce shortages out there, is another way to provide consultation with other professionals, such as primary care, who are seeing many of our people, obviously in many of the rural areas of the country. So it is a way to bolster the workforce issues in many systems. But there's a lot of uncertainty. I think there's been a real buy-in to telehealth strategies as we go forward, but I think we don't know how regulatory bodies are going to treat that long term if we emerge from it. And B, I think we need to take a better look at, well, what is the data telling us? How beneficial is it for improving outcomes for people? We saw no-show rates decrease for sure, but overall, long term, what is the balance between telehealth type of visits and face-to-face visits for people with mental illness and substance use disorders? We also know during telehealth, generally in rural communities, may have been a little bit more accepted prior to the pandemic, just because of the practical need for it in many rural communities. When the switch got flicked and providers had to take it on, rural and urban and suburban providers jumped on board and took advantage of it. But whereas rural providers may have been more accepting of it early on, they still did face, and still do face barriers related to broadband access, poor cell coverage, limitations in individual phone plans. I mean, that's broad beyond just rural too. But telehealth, getting telehealth services and capacity out in rural areas is a big challenge. And so even though we may have lots of regulatory flexibilities that have been put in place, there's still many people who can't access that type of service. And one of the questions, I think, and it's something that we're taking a look at and watching, is, will any congressional infrastructure bills that hopefully are coming down the pike create even more opportunities to expand broadband access and technology in communities, including rural communities. I'm going to hit on some specific slides related to substance use disorders. I will let Dr. Podesta, carry that later on when she speaks as well, but I'll just hit some of the highlights. In March 2020, SAMHSA granted states and outpatient treatment providers the flexibility to provide patients with more take-home doses than what federal regulations basically allowed. SAMHSA and the Drug Enforcement Agency provided guidance on implementing flexibilities affecting the delivery of medications to patients who are quarantined. And the DEA also authorized OTPs to add mobile components to dispense methadone, which we're starting to see, I think, a bigger uptake in systems across the country for sure. We also saw the DEA and SAMHSA work to ensure that authorized practitioners could admit and treat new patients with opioid use disorders during a public health emergency. And these flexibilities allowed for the use of audio-only telehealth encounters for buprenorphine induction without requiring an in-person evaluation or video interface. And a couple of state examples that I listed here, Rhode Island created a 24/7 buprenorphine hotline that offers access for people seeking initiation. Pennsylvania lifted a requirement for prior authorization for Sublocade. And other states like Virginia, Massachusetts, and California extended the length of prescriptions and authorized automatic refills for medications. So these are just some of the things that states did and systems did to increase access to buprenorphine. We also saw some additional strategies that were put in place. So states, we know, can adopt regulatory and policy strategies to reduce barriers to treatment. For instance, allowing initiation of buprenorphine without the in-person visit, alternate dispensing methods for methadone, eliminating or suspending counseling requirements for medication-assisted treatment, using Medicaid to support virtual counseling and peer support through telehealth and telephone. So those are some additional examples there. I also thought it was important to share some thoughts about homosystem response. And we know that so many of the people that we serve with serious mental illness and substance use disorders experience homelessness or substandard living conditions. And we know that there was a pretty rapid response in Congress and through HUD and local homeless continuums across the country to try to make sure that people who are homeless were being cared for, were making additional efforts to get people off the streets, we're getting people vaccinated, all of these things with a lot of good success. And there's been a tremendous influx of dollars in this space too. But some concerns, the Delta variant for sure may be resulting in a sustained impact to homeless population, especially where vaccination rates are low. When you look at some of those states across the country where rates are low and numbers are still high, you can imagine some of the challenge that it's placing on homeless system and homeless providers, and certainly people who are homeless themselves. We saw shelters closed, and we also saw some shelters that were specifically assigned for people with COVID or who were quarantined, and some who did not have COVID, to try to make sure that there was enough social distancing. We saw many of the homeless systems take advantage of hotels as temporary and maybe even somewhat long-term measures to enable a non-congregate approach to get people off the street. So rather being in a large shelter, with many people congregated in one single space, hotels provided an opportunity to get people in their individual spaces, at least on a temporary basis. Service availability has been a challenge, as we know, and mixed. And the significant federal housing assistance dollars are and will benefit people with mental illness and substance disorders. But I think the key thing to think about there is, just because there's a lot of new money to help get people off the street doesn't mean there's enough housing. We have a significant vacancy problem in the country for people, and a lot of it is also going to have to take new affordable housing capacity to be built, and that's going to take some time. So I'm going to start wrapping up in a second. I think some considerations for the future. COVID's here, and we need to almost shift from a pandemic approach to more of an endemic approach. Epidemic approach. How are we going to manage this over the long term in terms of the people that we're serving? We certainly need to encourage people with mental illness and substance disorders to get vaccinated. It's especially important due to the co-occurring chronic health conditions that many of our population experience. And we know that when people have complex co-occurring health conditions, COVID can just be devastating on people. I think we have to sort out what telehealth looks like over the long term in the field. I think this pandemic also really triggered the need for us to consider alternatives to site-based services. Many systems still heavily rely on day programs for people, and there's a lot of mixed data on the outcomes of those things going prior to the pandemic. And it really forced programs to shift on the fly to serving people in more community-based settings where they live. We have to think about what that looks like going forward. I wouldn't recommend that we just revert going back to site-based services in all instances as we emerge from the pandemic. We also really need to think about urban and suburban and rural service delivery and what that looks like. We need to do it prior to the pandemic, but we also need to look at it in a new environment as we go forward. We also really need to continue to think or rethink our approach to housing services in congregate residential settings for people with mental illness or other disabilities towards more integrated approaches. We know that evidence-based practices like permanent supportive housing exist, but really not taken to scale out there. Oftentimes those services, those programs don't have enough staffing to support their need. But we also know that, certainly at least in the COVID context, congregate residential settings, at least from a COVID perspective, may not have been the best thing for people with serious mental illness. And we also really need to think about, again, this is pre-pandemic too, but the workforce going forward. And certainly, in pandemic type of environments, making sure that our providers are treated as frontline workers, first responders, and have access to PPE that they need, like other first responders. And just a few takeaway points. A lot of this information that I'm talking about, I think many of you can realize, is anecdotal at this point. There's some emerging data. There's lots of data that we're not collecting, but we just have to keep that in mind. The Delta variant is prolonging the effects of the pandemic in communities, especially in states with low vaccination rates and low utilization of masks. That's concerning as it relates to the psychological and psychiatric stress for our population, particularly our seriously mentally ill population, as we go forward. And I'm definitely worried about that. The sudden withdrawal of an already limited mental health and primary workforce in communities reduced access during COVID, especially face-to-face access. It's rebounding now for sure, but it'll be interesting to see what the long-term effects of that are. COVID led to a massive natural experiment and rapid and widespread implementation of telebehavioral healthcare. That's pretty clear for sure. And lastly, whereas there was a general acceptance of telehealth prior to COVID, rural communities had a harder time expanding use due to technology barriers. And I will end there. And Jen, is that coming back to you or turning over to Becky?
I think we'll go ahead and thank you for your presentation and let Becky go ahead and get started. Thank you.
So, hi everybody. Thank you so much to the National Dialogues Conference organizers and everybody else for giving me the opportunity to present today. I'm going to focus on the intersection of evidence-based practices and sustaining those services and monitoring those services during a pandemic. So Jessica, if you could go to the next slide. Awesome. So just want to give us a little bit of context to make sure that we're all working from the same set of notes and we're all using the same operational definition. So SAMHSA estimates that 1 in 5 adults in the US are living with a mental illness of some kind. Serious mental illness, or SMI, is a subset of the larger population. And they estimate that about 13.1 million adults in the US are living with SMI, which is 5.2% of all adults, just to give you some context. And then Jessica, if we go to the next slide, I wanted to bring this up to show you that we're seeing changes in the number of people who have been diagnosed with SMI over time. We started to see a split in the data around 2016, and it's continued to increase in our 18 and older, our 18 to 25, and then that 26 to 49 population. There's no one single cause for these changes, but it's important to note that the population may be shifting, the ages of those populations may be shifting, and we're seeing more people being diagnosed with SMI. And the cells highlighted in yellow in the table below, so the data for 2018, those are statistically significant differences between 2018 and 2019. That doesn't happen very often. So I think it's important to note that something is happening, but this is all pre-pandemic. So there's no one single cause that can be attributed to these changes. We could go to the next slide. So one of the tools to treat people with a serious mental illness are evidence-based practices, and they blend the best research available with the science and clinical expertise in the context of patient characteristics, culture, and preferences. And I think it's really important to note culture within this context. Not all evidence-based practices have been measured and modified to serve all populations. So while we use them as much as we can, it's important to keep the cultural competency and those cultural considerations at the top of our mind as we work with different populations, just to make sure that we're respecting them and meeting our clients where they're coming from. Because these evidence-based practices are based on research, there are very specific protocols that providers need to follow in order to deliver these services to fidelity. So fidelity measures ensure consistency in service delivery across all of the providers. Fidelity measurement happens in different ways in different places. My experience has been primarily with the publicly funded behavioral healthcare system. And within that system, those fidelity measurement tools have been used by either states or individual contractors who have been brought in. So states need to verify and make sure that that service is being delivered consistently across all of the providers. The best way to do that is by measuring that fidelity. This can either be done by staff within the state government or bringing an outside contractor in to conduct those fidelity reviews. And assertive community treatment is one of those evidence-based practices, and that is the primary focus of a lot of the work that I'll talk about later, but it is not the only evidence-based practice that was impacted by COVID. And as Kevin mentioned, supported employment, supported housing were all affected by COVID. And those too have very specific protocols and ways in which those services are intended to be delivered. So if we could go to the next slide. So COVID hit March 2020, and everybody had to scramble to figure out what was going on and figuring out changes to regulations and guidelines and rules. And all of this varied tremendously by state, by county, by municipality, by cities. And we saw that variation play out. And as Kevin mentioned, those differences in rules of what was allowed and what wasn't, and where people were allowed to be versus where they weren't allowed to be, would impact service delivery. Some of the big issues that we found were that providers were unable to have clients within their clinics. So if you can't have people coming in, it makes it harder to treat people. You couldn't deliver services in person because of social distancing and that kind of stuff. And for ACT and supported employment in particular, a lot of those services are intended to be delivered in the community. So not just in a clinic setting, but if you can't pick somebody up and put them in your car to take them to whatever setting you intend to do those services in, you're not able to deliver those either. They were unable to facilitate group sessions. Group sessions are a big part of some of these treatment protocols. And if you couldn't do them, that was real tricky. And the groups gave clients the opportunity to be with other people, to reduce some of that isolation. So the inability to facilitate those group sessions, I think, contributed to some of the isolation that our clients were seeing. And on top of all of that, you've got the impact of clients' fears on treatments. So while the clinicians who are already doing incredibly hard work with an incredibly tricky population, and they need to figure out their own safety and comfort levels and manage kids at home and all of the other things and people who are sick and quarantined, you have clients who have their own individual feelings and responses to this pandemic that really changed how everybody was able to do their work. So if we go to the next slide. So while everybody's trying to figure out how to keep treating our clients, how to stay in business, how to cope personally, there was the added challenge of what to do with fidelity. And immediately after the pandemic started, so March, April, there were two groups who joined together to start doing some national calls around how to deliver assertive community treatment services in the middle of a pandemic. And they helped providers to get super, super creative in how they were delivering services, different ways to think about service delivery. But one of the things that came up on those calls was, what do you do about fidelity? We can't not measure how services are being delivered. It's important for states to know that the providers that they're contracting with are delivering services to fidelity. But how do you do that? Can you conduct reviews remotely? Should you even be doing reviews? Should you be looking at this from more of a continuous quality improvement process and have those reviews be more of a check-in so that you're, or TA, so that you're laying eyes on things, you're seeing what's happening, but you're not measuring fidelity? Or do you go ahead and do those reviews? And if you decide to do the reviews, can you do them remotely? Do they produce results that are comparable to in-person reviews? It was a super tricky landscape for a while. We could go to the next slide. So as I mentioned before, providers were super creative in delivering these services. Much like Kevin said, a lot of this is anecdotal, but we had providers who were sitting in their car in the parking lot and had their client have their apartment door open so that they could see each other and interact, but then be on the phone so that they maintained social distancing. People were meeting in parks and, med drops, making sure that these clients had access to the medication that they needed were tricky. The clients had been coming into the clinic to get their medicine. What do you do? How do you do that? So we heard some providers who were meeting their clients in parks, and the provider would put the medicine on a park table or a park bench and walk away so that the client could then come to pick up their medicine. They got real creative in ways to make this work. And for an already tricky and complicated population of people to serve, I think the providers deserve a tremendous amount of respect for the ways that they modified what they were doing and figured out how to make things work in this super complicated environment. As Kevin mentioned, the increase in telehealth was fantastic, but there was a lot of resistance on those national calls from providers about doing telehealth with clients who've been diagnosed with SMI, saying that clients couldn't use the technology, they'd be uncomfortable with the technology, they didn't have the technology. So some providers went out and found funding to pay for them to be able to provide their clients with smartphones or tablets or prepaid phones to ensure that those clients had access to them, teaching those clients how to use those tools. And this was a surprising moment, because as they started to do this, we kept hearing stories on those calls about how well the clients were responding. The clients enjoyed learning new things. They felt supported in ways that they hadn't before because those providers had to get super creative. Some clients really preferred the telehealth approach as opposed to being in person. They felt seen, they felt heard, they felt like, because the provider, the clinician, had to be looking directly at the camera as opposed to writing on a piece of paper or doing something else at the same time, that they felt seen and heard in a way that they hadn't before. And I think that's really important to note. As that hesitancy existed, the clients ended up liking it more than anybody thought that they would. And then the remote reviews. We tried it and it worked really, really well and was pretty fantastic. It took us a while to iron out the details. A lot of the issues were around remote access to electronic health record, electronic medical records was one of the most challenging aspects. But as providers got more creative and figured out how to make things work, we found ways to work through that barrier of getting fidelity reviewers access to those systems. And for providers who hadn't moved to electronic systems, we found ways for them to send copies of records in secure ways, to load those files onto a secure FTP and allow the fidelity reviewers to see the records, but maintaining HIPAA and privacy and confidentiality. And it was a tremendous moment. Our reviewers were real hesitant, and several of them didn't really think that it was possible to do these reviews remotely, but we did it and it worked, and it was pretty fantastic. If we move to the next slide. So how do we carry these changes forward? Continued emphasis on telehealth, making sure that stakeholders, that states, that CMS, that everybody continues to recognize telehealth as an important and effective way to treat clients with a serious mental illness. Bring back service delivery in the community, but with an emphasis on new skill development. As providers had to get creative in how they were delivering those services, they got real creative in helping those clients develop new skills. And as those clients developed new skills and got more confident, the clients wanted more of that. So providers are going to have to continue to be creative in how to deliver those services in the community. At some point, we're going to need those fidelity tools to be modified to acknowledge the efficacy of telehealth. Most of the assertive community treatment in particular requires face-to-face, in-person service delivery. We found that it can be done remotely. The tool doesn't allow for that. So at the moment, states are being penalized by delivering services remotely, even though we know it works. So at some point, we'll need to get SAMHSA and others to modify those tools to allow for it. And we need to keep being creative in our service delivery. Those clients reported feeling super supported and comfortable and enjoyed learning these new skills. I think while we're talking about fidelity too, it's important to note that the fidelity reviews produced comparable results across the board. So in-person and remote produced pretty similar results. Now, we did have some interesting issues related to timeframes and what time frame to look at in terms of record review. That got tricky for us in a couple of different places. In one of our states, made an executive decision, because we did those reviews over an entire fiscal year, but weren't able to start until October of 2020, with the pandemic really picking up speed in March. But knowing that while we started those reviews in October of 2020, we wouldn't finish all of our reviews until the end of June of 2021. And how do you make those reviews consistent across that giant time frame where providers were learning and growing and modifying and getting better at their service delivery remotely? So for some providers, at least one state chose to isolate a time frame for record review before COVID hit, and kept that consistent for the entire fiscal year. And that allowed some consistency for those providers to not get penalized because they were reviewed earlier in the year and before they'd figured out how to fully do all of this remote work. That was a really important thing to keep in mind, but it worked, and it worked really well. The providers preferred the remote reviews. We found that they felt that it was less burdensome. They didn't have to find space for us. They didn't have the disruption to daily services of having people in their offices doing these reviews. And the clients really liked being able to talk to us over the phone instead of in person. We'd been doing a lot of those client interviews with Fidelity reviews in group settings before, but this allowed for individuals to tell the Fidelity reviewers what was going on and how they felt during that transition. And the clients had such amazing and wonderful things to say about the work that their clinicians were doing, that their teams were doing. And it was really just an absolutely fantastic thing to see. And then I think my very last slide, if we go to the next one, is just some additional resources that may be helpful as you think about how to continue to deliver these services, how to measure service delivery over time. SAMHSA's Evidence-Based Practice Resource Center is a fantastic resource. And I got super excited when I saw that we had some new information from like June of this year on telehealth and treatment for people with serious mental illness and substance use disorders. SAMHSA has 4 brand new evidence-based practice and SMI-related publications on their website, and 2 other resources: the Mental Health Technology Transfer Center, funded by SAMHSA and awarded by SAMHSA region. So Region 10, which is the Pacific Northwest, specifically based out of the University of Washington, focuses on evidence-based practices. So they have a whole bunch of different resources on their website at the link that I've got set up there to help you think about how to do things differently. And then the final one is the University of North Carolina at Chapel Hill Center for Excellence in Community Mental Health COVID resources. They have a ton of different resources, and those national calls that I mentioned were facilitated in partnership between the University of North Carolina Center for Excellence and the Mental Health Technology Transfer Center. And there are links at that website for the forum, where people have an opportunity to informally talk with each other about what's working, what's not working, how is it going, and links to the calls that are continuing. During the height of the pandemic, those calls were happening once a month, but they've gone to quarterly now. But it may still be helpful to people who are trying to figure out how to do things better, or curious about what other people are doing and looking for new and different ways to approach this problem. Those resources may be real helpful to you. And I think, Jessica, if we go one more, then that's my very last slide. So thank you so much. And if you have any questions, feel free to reach out to me. Thank you so much.
Thank you so much, Dr. Helfand. And now our third presenter is Dr. Podesta.
Hi, everybody. Today I'm going to present really piggybacking on what Becky and Kevin were speaking about, talking about these times that we're in now. And I'm going to talk about just an update on substance use disorders. As Jan did say, I am a specialist in an MD specializing in psychiatry and substance use disorder. And I have been working in this field for a while. I wanted to make a silly correction. I guess it's not that big a deal, but Jan, it was 2012 that I opened my practice, and I think I heard you say 2020. So I've been at it a little longer than it sounded like. But I just wanted to, I'm glad to be here. I'm glad to work with you all. All right, so here we are in lovely Louisiana. These are my disclosures. We're going to talk about substance use disorder during the pandemic. So as you can see, this was the CDC director from a little bit ago. COVID really screwed up those with substance use disorders just as much as it did with those with serious mental illnesses that are not substance related. I have so many stats, I've got so much to say, and I don't want to overdo. I don't want to read through and just show you stuff that you probably know a lot of stuff. So I'm going to highlight things, but the big news is lots and lots of fatal overdoses in the 12 months that we cataloged, May 2020 to May 2021. Those are the most recent updates. It's the highest number reported in a 12-month period in US history. We've had loads, we've had some problems where drug testing has been decreased, but for those that have been getting drug tested, there was a 35% increase for non-prescribed fentanyl and a 44% increase for heroin. And I have to tell you, I was in my reentry court this morning and we had so many positives for both of these. And we were out for the hurricane recently. And then before that, we were out for COVID. And so we've been unattentive, just like Kevin and Becky were highlighting. We've not been able to have face-to-face as much. And so in court, these guys, just kind of sank back into their habits, increased fentanyl, increased amphetamines too, increased benzos, increased cocaine. And, we know that fentanyl can be very, very fatal easily. And there's OD fatalities involving cocaine up 26%, probably because it's combined with fentanyl. And unfortunately, the drugs that people think they're buying, oftentimes they don't think they're getting drugs with fentanyl in them, but they do have fentanyl in them. And so it's not detectable as on a basic drug screen. You have to do an extra drug screen for fentanyl specifically. Same with methamphetamines and stimulants, increased overdose fatalities, a lot of fake prescription pills, pressed Xanax, pressed opiate pain pills, pressed Adderall, pressed whatever else that you can think of, but fake prescription pills. So if you get it from a pharmacy, it's bound not to be fake. But if you get it from a friend or on the street, easily could be fake. And so a lot of those have fentanyl in it too. And so I try to warn my patients about that. And as evidenced by my reentry guys this morning, a lot of them had marijuana and fentanyl in their system saying, oh, I never used fentanyl, but it's probably in the marijuana. Anyway, increased alcohol, we are very well aware of that. And then NIDA did a study regarding 8th to 12th graders in 2020 and increased vaping and increased amphetamine use in 8th graders. So check these numbers out. They're pretty significant. Just another way of representing this information, this graph on the right just shows an increase in the overdoses and fatal overdoses. So here's some numbers. I don't want to go too deep into this as we just talked about a little more detail. Think about what state you're in. And let's look at the numbers by state, February 2020 to February 2021. And so increase in national overdoses, still a problem. It looks like New Hampshire, New Jersey, and South Dakota did not have that increase, however. So if you're there, you're doing something right, or you're not collecting data, probably doing something right, but I don't know. Anyway, we really are in a pandemic, within a pandemic, as you've probably heard people say. Okay, so here we go back to the beginning of the pandemic. This is 2019 to 2020 in May regarding overdoses. And this is through a source called ODMAP, which if you're in a state that does, or in a city that uses ODMAP, then you get to collectively put your data into this. And it's not the CDC stats, but it's self-driven by health departments. Pretty great tool to access in a kind of more real time than what we do when we collect CDC data, which is collected and reviewed and compiled, but it takes sometimes years for that. So this is more real time. What about naloxone administration? That is one way that we can tell in more real-time data of naloxone use, like what's going on in the community. So the long-term trends from 2013 to 20, EMS naloxone administration has an increased annual rate of 14.5%. So it keeps trending up. That makes sense. That's why we've been why we've been trying to open the door to more naloxone. In the past 3 years, 2018 through 2020, so not quite 3 years, the number of naloxone administrations was increased by another 17.6%, and then et cetera. So you can see on the right, the kind of sawtooth pattern of that graph, but trending up heavily. And then this is another way of looking at similar data, but just trending up again with naloxone use in New Orleans specifically. Well, you guys heard from previous speakers about some of the problems. I'm going to highlight them and talk about solutions. In substance use disorder, substance use is a disease of isolation. When we isolate, when we physical distance, when we social distance, when we don't have facilities, we are unable to, really the addiction tends to win. So even folks that had really good recovery because of isolation and because of physical distancing, having less facilities, less activities, less AA meetings, such as then, people really did sink, and there were a lot of slips that turned into real relapses. And of course, some facilities had to halt admissions or decrease their census so that they could keep a certain level of distance. Also, of course, workers were not available. And then, believe it or not, there was also a shortage of naloxone. And so it could have been because of refocusing funding by Pfizer to deal with the vaccine development, or it could have been for a supply chain problem or a variety of things. But nevertheless, we had less access to the medicine and we had less of the medicine, especially at the beginning. And then we have loads of telehealth, and you heard you heard them talk about broadband and some improvements. One of the problems was actually an improvement in healthcare and in access, but of course we still have problems with broadband and problems with devices. So much financial stress for so many people, and then loneliness, and then coping skills. And then you already heard about the face-to-face outpatient and IOP, and also mobile units, such as street teams being unavailable, drug testing unavailable, outreach scaled back. A lot of people are bored, and a lot of my patients that are in great recovery, they talk about their distractions such as work and hobbies and loads of things that they do, or it's the only thing that keeps them in sobriety. And then minimal peer support, although there's more access, more regularity, 24/7 peer support virtually, but it's all virtual. Other problems, people were saying, first responders were saying they would find people down with a lump of money in their pocket that was right around the time of the stimulus check. So that was a big peak in overdoses, because people were just getting this lump and like jumping in. A lot of pharmacy difficulties. Had some issues where we couldn't get medicines, or we couldn't get, people moved from one state to another because they were no longer working. So they would move back with their family in the country or in another city. And we couldn't just prescribe medicine. We had a real big issue during Hurricane Ida for a couple of weeks, actually, where a lot of my patients had a problem getting their pharmaceuticals that was helping sustain their treatment and recovery. You already heard Kevin talk about the issues with methadone clinics. They weren't able to give daily doses. They went virtual. And then folks were dissuaded from going to the emergency room unless they had COVID. So if they didn't have COVID or COVID-related symptoms, they were basically suggested, or they had the idea that they shouldn't go in, or if they didn't want to go in, even if they were invited, because they might get COVID because everyone in the hospital has COVID. So a lot of fear and a lot of confusion about how to use the hospital setting for help. A lot more illegal drugs came in, just happened. We got shipments, we have fentanyl everywhere right now. There's reduced access to overdose treatment, such as naloxone and EMS and such first responders. And then the synthetic fentanyl is just massive right now. It's available and it's a very high rate of overdose and death with it. And so you heard Becky talking about some of the studies. So this is a study, I don't think she touched on this. It was about the predicting the effectiveness of harm reduction programs. There's, harm reduction is a piece of treatment. Someone might need treatment, but all they are ready for is harm reduction, which is fine. And I just want people to get their foot in the door. Many people never go on to full treatment and abstinence. Many people do, but we have to start somewhere. So harm reduction is really under the umbrella of treatment. It's just maybe possibly one of the first steps. So anyway, the effectiveness of current treatments related to harm reduction were tested on 9 measures, reducing prescribing, drug rescheduling, et cetera. You can read that. And then it was over a 5 and 10 year period, what was measured related to opioid overdose deaths. The prediction was that we would have increased opioid related deaths from 2020 to 2024 of 547,000. So, and then continue to rise by double that, by over 1 million. And they said that this study found the most effective program in preventing fatal overdoses were efforts to expand naloxone. We've already talked about that by 30%. That would reduce opioid overdose deaths by 25%. And then also the other things that were beneficial were pharmacotherapy, which would be like medication assisted treatment or medications for opioid use disorders, such as methadone, buprenorphine, naltrexone, and other MATs, syringe exchange, needle exchange, psychosocial treatments, and prescription monitoring programs. Very, very effective. The efforts that have been made to reduce the prescribing, so that was when we limited being able to prescribe large amounts of opioid pain pills, as you've seen from things like the pharmacist, like TV shows like The Pharmacist and movies that you may have seen, has helped. But it would predict an increase in heroin deaths in the short term, which is what happened. And then the rescheduling of drug over years would increase the total deaths over 5 years, as some opioid users would escalate to heroin use, but then decrease the deaths over 10 years. So it's just, it's kind of, I think of addiction and supply and demand as like a whack-a-mole situation where, you pull back on what a physician is able to prescribe, and the market, the demand is there without the enforcement ready for it. And so so then we have a spike in heroin that has fentanyl in it, and then people die, but then hopefully that balances out with more enforcement. All right, so there have been some solutions. I know I was painting just a really dark picture, but we have solutions. So as you heard, you've heard of some of the solutions already. I'm going to recap some of them. The DEA now allows controlled substances to be prescribed via telehealth as of March 31st, 2020. And that has been really helpful for not just people needing Adderall and Xanax and OxyContin, but really for people needing buprenorphine products. That is a lifesaver for our patients that are in recovery or in treatment requiring buprenorphine for their sustainability. And you can also still get early refills of controlled substances. So Schedule II medicines are able to be refilled early. And as a practitioner, as a prescriber, I'm able to order multiple prescriptions of a 90-day supply. So that helps me, that helps the patient, so they don't have to see me, or I don't have to write a prescription every 30 days. So that's actually really helpful. And so I do all of my stuff electronically. I prescribe everything electronically, and that even has been adopted much wider. So that's fantastic for all around. The Department of Health, I mentioned ODMAP, you saw that picture of the graph of kind of more real time. So 2017, there were just a handful of states that joined in the data reporting. And now over 48 states are logging data. So that's really helpful for keeping a real-time estimate, just like we have dashboards on every Department of Health for each state and also federal on COVID deaths. We now have almost a dashboard for OD map for opioid overdoses. I think that's important. You got to put a lens in it to make a change. In March 2021, we had, there was the rescue plan with the largest amount of funding, $30 million for overdose and harm reduction services. And then, you know, the Ryan Haight Online Pharmacy Consumption Protection Act of 2008 was created by Congress to regulate online internet prescriptions. Now that we're virtual, and now that we're like, I need to write that prescription, and I need to write it through telepsychiatry. So it used to not allow, you used to have to see a patient face-to-face at least once to initiate a scheduled medication such as buprenorphine. And it turns out now, because of the restrictions being loosened because of COVID, we're able to have a we're able to have like a telephone call with a patient that provides enough information, and it allows us to write the prescription with that as opposed to a face-to-face or a video conference. So that's good. That might stick, that might not. So that's kind of what Becky was talking about, needing to be able to continue having access. And I don't know how long we're going to be able to have that exemption on the Ryan Haight. We talked about methadone being very difficult to get at first in the pandemic because they weren't doing face-to-face, and you're not allowed federally to do take-home doses. And so these rules have been relaxed very much. So you still are required to have a in-person for new patients. So the very bottom bullet, in-person evaluations for new patients are required. And so there's some really creative tools that prescribers are using. And they're using mobile vans to do that initial inpatient visit, and then being able to allow the patient to get their methadone virtually from there on out. So that's pretty amazing. For new buprenorphine patients, we still we're able to do virtual appointments. And then for current patients, all can be virtual. More state health departments are focused on naloxone available in the public. Believe it or not, in Louisiana, I think it was 2012, we were trying to get naloxone out to folks, and the board, our medical board, was trying to sanction us for and tell us not to do that because they felt strongly against naloxone. That was almost, it was about 9 years ago, I believe. So things have changed in a very good way. I'm very happy to report that, and more so even now. There was a study that some of my colleagues were involved with. It's a NIDA study. It's called ADAPT. And, you know, one of the big problems right now is we don't have any medication-assisted treatment or pharmaceutical treatment that is effective and evidence-based and approved for methamphetamine treatment. And methamphetamines are the next big wave. So even though we're, you know, still struggling with loads of opioid overdoses, the next thing to hit, and several of my guys in court this morning did have methamphetamine in their system, is methamphetamine. And so there was a big study, and multi-center study. I think about 500 individuals were the study participants, to study extended release naltrexone, so Vivitrol, plus bupropion, so Wellbutrin, to help with methamphetamine use disorder in cravings and in abstinence and treatment. And this study showed pretty good results, a low response, but higher than placebo, but overall the cravings did decrease and the abstinence time did increase tremendously. So more solutions. Now we, you know, for those, I don't know how many of you know this, but buprenorphine prescribers had to go through MDs an 8-hour training, and NPs and PAs a 24-hour training or 20-hour training. And now just in April of this year, anybody that has a DEA number, so any prescriber that has their DEA number can apply to SAMHSA for a waiver for a buprenorphine dispensing or a buprenorphine license, or what's called an X number. And so if you have an X number, then you can see 30 patients during a month's time and prescribe buprenorphine for 30 patients during a month's time. And what's amazing for that is it's not like now we have all these treatment providers that are suddenly going to be doing addiction treatment. No, it's just one more tool in a primary care FQHC's clinic's toolbox. It's one more tool in, a emergency room nurse practitioner or an urgent care nurse practitioner in their toolbox. If someone comes in and has addiction, opioid addiction, and buprenorphine would be appropriate for them. Just one more tool in that toolbox, and then move them over to addiction specialist or an addiction clinic. So other solutions, we are using bridge programs to expand MAT. And so that would be where someone goes into the emergency room, has because of an overdose, and then they get bridged right into treatment with like medication assisted treatment like buprenorphine or naltrexone, Vivitrol. We have care coordination and case management. There's a lot of apps and tools that are becoming more and more available. What we know is that all of us in mental health and behavioral health, we're siloed away from primary care. We're siloed away from emergency room. Usually we're siloed away from hepatitis C treatment. We need to bring that all together. And I want to commend Jan Kosofsky, who introduced us, on being part of that for the program that she's working with, because it brings people out of silos so the patient doesn't feel like they're running around or lost, or that there's splitting of care. And so we need care coordination, case management to be more robust. And there are just apps and tools through EHRs. I've been working with a group called Sage Surfer, and they have a great care coordination platform that's really amazing. Things have not been widely adopted, but NIH and HHS are encouraging those developments. We have digital therapeutics. I don't know if you guys know this, but these are prescribed apps essentially that are prescribed, and insurance covers, Medicaid doesn't, but insurance nationwide covers Reset and Reset O, and that's for addiction treatment. So there are these apps that are 12 weeks, and I can tell you more about that if you have questions. But there's also tons that are non-prescribed, but the ones that are non-prescribed, the clinician, the physician doesn't have any say or any review of, whereas the prescribed ones, you get a review of them. And then lots and lots of peer supports that are really excellent, such as notonemoreroom.net or notonemore.net, intherooms.com. And these are peer supports that are 24/7 available, which we didn't really have that much of before COVID. Smart Recovery, Recovery Dharma, they all have meetings that are online. And, so if someone wakes up at 4 a.m. and that's when they start spinning in their mind cycles and they're worrying and they start having cravings, they can go to a meeting in London that's on live on their app or on their smartrecovery.org. They can go to Reset if they had that prescribed by their physician. They can do so many things that weren't available before. So in conclusion, addiction, we know it's a complex disease, complex treatment needs, thrives in isolation, and we have really been hard hit in this field, mental health and addiction. Like I said, it's a pandemic within a pandemic. There are lots and lots of tools though, and being creative, like Becky said, is key. We have to be creative to help our patients, to help our clients, to help our communities navigate through these new tools and create more tools as well, and make sure they're evidence-based. Different states have responded differently, and that may be a good thing, but it would be great to have more studies related to understanding what has been the most superior. And we have to think about best practices for substance: prevent, screen, treat early, use multiple treatment modalities, including medication-assisted treatment. All right. Thank you so much. I appreciate you listening, and I believe that I'm passing it over to Jan right now. So let me stop sharing. All right.
Okay, thank you. That was terrific. All three of you, appreciate the presentations. And now I'd like to see some questions from our audience. If there aren't any to start off with, I have a few questions. So, okay, I'll start with Kevin. Kevin, I'm very interested in the whole idea of people getting vaccinated, as all of us would love our lives to get back to normal. And do you have any idea on any special approaches that are being formulated or being tried to do outreach with people who have a mental illness or substance abuse problem? As Dr. Podesta said, oftentimes primary care is completely segregated from behavioral health, and this may be a time that really is critical for people's lives, once again, to bridge that.
Yeah, thanks, Jen. I mean, I don't know that I have, specific examples, other than I think what's important to say is, when you talk about, if the workforce is, resuming, face-to-face and contacts with individuals, to the extent possible, the types of relationships that they have with people, the health education, I would joke around with folks when I first came into the field as a mental health worker in a day program. I always felt my job was to convince people that they had a mental illness and convince them to take their medications, and that was not the right approach. And when you think about really, having relationships and developing rapport with people, providing health education to them, beyond just, you have a mental illness, take your medication, especially given that we know that, so many of our folks have, co-occurring, chronic health conditions, being able to have that rapport and provide that health education to individuals, and then being able to provide integrated healthcare solutions so that, mental health and primary health care are not just seen in totally separate silos, but that if you have whether it's a psychiatrist or a behavioral health case manager working with an individual, that they're really also integrating care with the primary health care practitioners to ensure that there's a consistent message that is based in education for people to help them, convince them to get their vaccination. So I wish I had more than that. And if it exists, I'm just not aware of it.
I just also get concerned. There's so much pushback when there's a mandate, but when we have congregate housing, I don't know how you can ignore the importance of it. So yeah, it's really critical. And especially in your presentation, you said higher possibilities of people who struggle with mental illness to have higher rates of COVID infection.
Yeah, and I think that a lot of that boils down to the education piece, right? So if you have underlying, chronic health conditions, whether it's hypertension, diabetes, whatever it is, to the extent that, you're learning about, health and your impacts of your health overall, and then layering COVID in there, you hope that it's a convincing argument. That's a bigger issue than just mental health, I think, as we've all seen over the course of the past year or so.
Well, the reason I'm pressing this is because I know that we've got participants from FQHCs as well as the public mental health system. And so with public mental health, there's always opportunities to reach out to the Office of Public Health. And when you do see patients in clinic, to offer in vaccinations right there. And certainly the FQHC is the same. But thank you.
And I would just add, not to belabor too much, but when we look at tobacco use for people with serious mental illness, it's so significant that the numbers are startling, right? And so where we have in the mental health field made really concerted efforts on tobacco cessation programs for people with serious mental illness, we've had some success there. Even if you look at, I think I've seen Brian Hepburn and Bob Glover, who's on the phone. Bob Glover took a lot of the lead on this several years ago with the state mental health authorities, tobacco cessation programs at state psychiatric hospitals, with good success. And if we can really apply that approach to getting people vaccinated, we could probably make some results.
I've got tons of questions, so I'm going to just keep on going until the participants decide to be brave and ask to. Dr. Helfand, I have a question for you, and that's with regard is, how do you measure for fidelity when the program itself is not being implemented in the way that it was designed as an evidence-based program?
It was super tricky. And that was part of the reason for looking at that, especially in that one state, looking at that time frame pre-pandemic, trying to capture. So we used February 1st to March 2nd to get that full 30-day period, and used that for all of our record review purposes to try to give them credit for the work that they were doing before things went sideways. And we're hoping at this point that as things get a little more normal and as everybody gets used to things, that we can take some of those modifications into consideration. So for this next year, the plan is to use the normal timeframes, the 30 days before we go out for the review, but to have a separate table in our record review to keep track of the amount of telehealth that's being done. We can't give you credit for telehealth, and we can't say that but we want to keep track of it. We want to note it. We want to be able to document it so that should SAMHSA, anybody come and say, hey, how much is this happening? Is it effective? That we'll at least have some documentation. And then in the written reports to give providers as much credit as we can for the great work that they're doing, even though it's not the way it normally got done. And it's a super tricky one. We delayed reviews for supported employment until the last quarter of the year because, as everybody mentioned, the job market was crazy and things were weird. And if there were already a scarcity of jobs, then people with SMI had an even lower chance of getting jobs, and it just got real complicated. So I think the key is to be flexible and to use as much common sense as possible, and then to just document everything that we can't give you credit for so that we have documentation should anybody start asking questions and be willing to make those modifications, that we'd have the data to support it.
So I see an awful lot of footnotes in all of your reports in the future.
And separating out data and separating out years and making sure that the telehealth and everything from March 2020 on is a completely separate chart and table within our reports to make sure that it's clear that we are separating out. The methodology for the reviews is different. The methodology for service delivery is different. The report writing got real complicated, but the bottom line was that the providers were making it work, and we just needed to document as much of their creativity and their work as we could to give them as much credit as we could, but it was a tricky year.
Thank you. Dr. Podesta.
Yes.
I get to ask all these good questions. So the table, the bar graph that you showed about the distribution, or I guess the use of Narcan going up and up and up and up, and then still the number of overdose deaths going way, way up. You know, that is so disconcerting, because you think about if those people weren't out there able to get to these folks fast, what it really would look like, the percentage of overdose deaths that we've experienced.
Yeah.
On Next Door Neighbor, I know a lot of people use that app to keep in touch. And I was watching a long thread of neighbors talk about the loss of their children due to opioid addiction and incarceration and all of this. And one of the moms talking about, because of the isolation, that even if they do have Narcan, there's nobody there to reverse it, and how incredibly sad it is. Because as you said, it's a disease of isolation, but it's also a death because of isolation too.
Yeah, I know. I mean, and that's why I think of it as like a game of whack-a-mole, and it's no fun, but it just keeps on popping up. And we have these tools, Narcan, and then we have these barriers like isolation, or someone has Narcan, but it's not with them. Jan, I was walking up my street about 2 weeks ago, and I was walking the dog. I don't have Narcan on my person. There was a woman on a house that's for sale. She was just starting to nod off, and I went up and just, kind of did a sternal rub, and she came back. And then when I walked back around the block, she had like slumped farther. And so I didn't have Narcan. I don't have any at my house. I have it at the clinic, but that's, 10 miles away, 5 miles away. So I had to call 911. And so even I, as an extra well-trained person, wasn't able to help this person other than calling 911. Granted, luckily she was out in the space in the community, but I was probably the only person that saw her just because time of day. And what I encourage for all of us as leaders in mental health and as people that make policy and also make procedures for our clinics, for our areas, is to influence your team members and whoever you can influence to get Narcan, to get that for availability, get it out there in the streets more frequently. You or someone else, may be able to save that life that could just notch one more down on the graph, but then we're going to have more fentanyl. It's stronger. It's in more stuff. It's in those pressed pain pills. People don't think these guys, I keep saying guys because my court thing is what I just came from, and 12 guys that I saw this morning. They don't think they're using fentanyl. They're not choosing to use fentanyl.
Correct.
They think that they're getting, my friend gave me a tramadol and, it makes me feel funny and I like it, or my friend gave me ecstasy and it has fentanyl in it. And so it's going to be more of a problem like the predictions were on that Stanford study. But then hopefully, ultimately, it'll be less of a problem. But we just need to be armed, ready, have these bridge clinics, have these solutions at hand, as soon as even if someone refuses treatment, we have to get them available for at least harm reduction.
I have one pop question for you. If you had to pick the 3 factors that were best predictor of someone doing well in MAT, what would they be?
Ooh, good question. So MAT, of course, encompasses let's call it medication for opioid use disorder. And so that would be methadone, buprenorphine, or Vivitrol, naltrexone. So they don't, I used to think they used to have to be adherent because it would be something that you take every day, except the Vivitrol, that's a monthly injection. Now Suboxone, buprenorphine has a monthly injection. So daily adherence is not necessarily one of the predicting factors. Willingness to go to a MAT provider, they don't have to be abstinent either. People can use MAT as a part of harm reduction to bridge into eventual recovery. It's not the most, I'm kind of stuttering because I'm like, I can tell you all the reasons that we used to think people wouldn't be candidates, and they're wrong. I think everyone with opioid use disorder that meets criteria for mild, moderate to severe opioid use disorder, not necessarily physiological dependence on pain pills like prescribed by a doctor, but actual opioid use disorder, compulsion, chronic use, use despite consequences, every single one of them should have medication-assisted treatment. I can tell you why I would choose one versus another. Of course, proximity, availability, that's number one. So for those of you that work in the criminal setting, this is something I had a conversation with the Department of Justice yesterday. Someone's in jail and you put them on methadone because that's the only thing you have in your jail. And then when you let them leave, when they get released, and sometimes they get released at midnight on a Sunday, at least from OPP in Orleans, and they live, 150 miles away from a methadone clinic, because there's only 8 methadone clinics in Louisiana. How are they going to get their methadone? So you have, starting in jail, you've set them up for failure. And so the planned access, not just planned access for tomorrow or today in the clinic, but planned access for long-term recovery, long-term treatment. So that's one huge thing. Another is what they want, whether they want to be taking an oral, they want an injection, they want to go to the methadone clinic daily, because sometimes the methadone clinic daily is actually, it's pro-social. It's good for those that suffer from the disease of isolation and lack of connection. And then between agonists such as methadone and buprenorphine and Vivitrol, I like to think of when someone was sober for a good 6 months in their adult life. And if they were lethargic and had malaise and no energy, and then when they took opiates, it gave them energy. then at least for early recovery, they should be on probably a partial or full agonist, such as methadone or buprenorphine. For those that even those in jail for 6-8 months, and and their energy was fine, they slept fine, they didn't have an issue, they just got out and started using heroin because that's what their acquaintances and buddies use, and it doesn't give them energy, then Vivitrol would be a great resource pharmacologically.
Well, thank you very much. Now we've got some really good questions from our participants. This is from Brian Hepburn, and I think that this is for Kevin. How do we do a better job in mental health with prevention and early intervention, especially in working with children and adolescents?
Thanks, Brian. I'll talk about it maybe a little more from a systems issue, and certainly would love perspectives on programs and services and treatments from Becky and Dr. Podesta. But in my mind, two things come to mind. One is I think it's important for the mental health system. I mean, when you look at the systems level, a lot of times the mental health systems, are structured differently with their state Medicaid agencies and things like that. And I think it's important for the mental health systems and authorities to really work as closely as possible with the state Medicaid agencies to come at it from an approach using the EPSDT requirements in the Medicaid world, which basically ensures or basically requires systems and Medicaid to cover these types of prevention and early diagnosis services for children and youth. And there might be strategies in there for those systems to come together about early identification, working with primary care docs and pediatricians to earlier identify people, using the EPSDT program to pay for services that may not currently be paid in systems, to try to develop those children's systems of care for folks. I also think that it's important for the systems as much as they can to really try to work with education, particularly within the local school level, but particularly the state departments of education on how they can identify kids in schools, build in the right types of behavioral health supports in schools. I mean, those schools in many communities across the country are really so critical in children's and families' lives. I think that's an important area to take a look at. So
here's a question that's for all panelists, and it's from Dr. Laughinghouse from Capital Area Human Services. She's looking to find out from you, how do you overcome resistance by the providers in moving to teletherapy? I've had exactly the opposite problem in my place, but so how do you encourage them? I think that probably most clinicians would say they want to do what's best for their patients and their clients. And so I guess any one of you want to talk about how you found that improved abilities to serve in some cases. I know my social workers have said it's given them a great opportunity to look inside someone's house and really do more a holistic approach to what's going on in that person's life. But I'll let any one of the three of you answer that question. What do you see as the benefits of using telemedicine?
I used it before the pandemic with some waivers from the state, and it was amazing. And I just would tell providers, some of the benefits, like you said, you can see their place, you can catch them, they have more access, they don't have to take an hour off of work for a half an hour appointment, or for some of my patients drive an hour to see me for a half-hour appointment, then an hour back. So the clinicians would likely be, I wouldn't imagine there would be resistance. I'm actually surprised to hear that some folks are having resistance, but allowing for a dedicated workspace for the clinician to have a private, quiet office, because of course in a cubicle you can't do good telemedicine or telehealth, right? So having a protected and safe workspace, and some of that could be from home if there's not kids running around, if there's not, but I have found it to be wildly successful for both my patients' enjoyment of some freedoms, for me to see into their homes and see what their life is like, a little more detail. Of course, there are some disadvantages, which is the broadband, the patient's inability to connect, maybe not having a proper device that has the video technology. So then you're stuck doing a phone, which some therapists actually think they do better on phone because the patients and the clinician are kind of just more connected and maybe just more, hopefully less distracted. So I think there's definitely the pros outweigh the cons. I'd love to hear from the other two speakers.
I think the no-show rate is probably lower. I don't have the data on it, but I would imagine that the no-show rate is much lower because they don't have to take an hour off of work for a half an hour appointment. And I think the efficiency gained in one's schedule by doing this and having fewer no-shows is another lever to push on to encourage the use of telehealth.
Mm-hmm.
I would add too, I mean, this may not be addressing resistance, but, you know, folks who've been, you know, doing individual private therapy or outpatient therapy, you know, there just may be an education and messaging piece that needs to come out with it. So, you know, if you're not really sure where to begin in doing, you know, teletherapy type of services, you know, what do you need to do it? Are there HIPAA concerns? Are there billing concerns? How do you bill for it? All of those things. There's information out there on how to address those concerns and do it. But that information just may not be filtering down to everybody. And I think that may also be an important aspect of this is how do we get good information out there to therapists in order to be able to feel comfortable doing it and make it so it's not such a huge lift.
I think it's also important that administrators really listen to what may be causing the resistance. You know, if it's an issue, the fact that they don't have a place in their house that they can be comfortable and set up a workspace that's going to work for them. I think it's totally acceptable if that person feels more comfortable doing telemedicine from their office as well. And we offer a mix of that. So it may be that they still would come in and have some collegial involvement, but also not have to displace their dog and cat and everything else to make their home work as an office. I'm gonna go to the next question now. This is from Tina Hicks. It says it's for everyone, and I think we all can understand why. She said she believes that trauma is a huge problem with substance abuse. And are we helping people with substance abuse deal with trauma that may be driving their substance abuse? Is it difficult to reach the trauma that drives substance abuse?
I will start. Yeah, I'll start. Yes, substance and trauma are not always inextricably linked, but very close. And for certain populations, very, very high. I would dare say, you know, in certain settings, like in places like where people have kind of dwindled down or gone off the rails, they're not actively using as like a successful, or what do we call it, like a alcoholic with a skiing problem or a skier with an alcohol problem or whatever. But when they've come off the rails and gone down the path of socioeconomic demise as well, there tends to be loads and loads of trauma involved. And whether that's cause or effect, it's really both. And so there's most of the treatment programs that I've worked with in the past couple of years consider themselves trauma informed. It was a SAMHSA push many years ago. And so insurances really look towards trauma informed treatment. And those are evidence-based models that really do get to the deep roots of trauma. I would say though, in early recovery, I find it a little bit of I shoot myself in the foot when I jump into trauma treatment too quickly because it unravels and people don't have the recovery skills really deep yet. And so triggers come up more and at the beginning of trauma therapy, and then we have to have more attention to the addiction therapy again. So, you know, it's a very fine line, but the trauma informed programs are very, very excellent. And I see that Becky, you're nodding your head, so I'm going to pass it to you.
Absolutely. I think the trauma informed approach is the best way. And I'm not a clinician. I haven't been in the field doing the work, but But the data that I've analyzed have indicated that those providers who were taking a more trauma-informed approach had better outcomes with their clients. So I think using those SAMHSA evidence-based practice things around trauma-informed care are the key.
Just that too, I think it's really important for us to push awareness about trauma and trauma-informed approaches beyond just the behavioral health workforce into primary care, frankly, even in, as we're talking about crisis response services, law enforcement, and their interactions with people too. So.
All right, the next question, Brian's helping me here. He is asking about the fact that the workforce shortages. Any thoughts on what may provide supports to behavioral health providers to help with retention and also helping with recruitment? So I think, Kevin, that was on one of your slides. So this comes to you first.
Yeah, I tell you, I think it's one of the top 2 or 3 issues that we face in the behavioral health field. And it's one of the things that we struggle with the most, right? And so, we can always make the case that we should pay people better. But the reality is, if we're paying somebody, $13 an hour to do really, really hard work, and we increase their salary to $17 an hour, that's important, but it's not going to be a life changer for them. And so money is important for sure. We should never lose sight of that. We need to pay our workers well. But I think there are other things that we need to think about as we go forward. And I think, support and supervision are absolutely critical, to our workforce. What types of support are they getting from coworkers? What types of supervision? We're putting, some of our least experienced and qualified individuals in some of the toughest situations out there, with very little support and supervision. And we have to make sure that, we're building that into funding and rates and things like that. And, that may require braided funding approaches, to the extent where, Medicaid is paying for more and more services. But things like this need to be built into, programs or providers' capacities to provide support and supervision. We've got to think about that. Safe environments, I think, are really important. When, especially when we have workforce shortages, and we start to maybe but sometimes there may be some situations where, crisis response is sending out one person into a challenging environment, or location of services or things like that. So I think generally a safe environment, and even in the COVID environment, how can providers make sure that they're doing everything they can from, personal, PPE and things like that to make sure that the workers are safe and that they feel safe in their environments. Training goes along with this, right? So to the extent that we're building in time and funding to make sure that people are getting some training on trauma-informed care or racial equity and diversity practices and things like that, they're going to be better able to do their jobs. And I think the other thing too is consultation, right? So especially if you're in rural areas or you're in solo practices, to the extent that there are consultation opportunities that exist for you, when you're working with a particularly challenging individual who may have co-occurring diagnoses or things like that, the availability of having those things out there just, I think, makes a person feel more successful in their job. So I think that's sort of the short list of things that I would rattle off.
I just want to add one that I think is really important, and that's flexibility. People have had a good long time to reflect on what's important in their lives, and they have been affected by the same things that their patients are coming to them affected by. But we had an outside consultant come in and do a focus group with different members of our staff, and really virtual was way up there, allowing people to have a flexible schedule. And you can do that when people say, hey, I can pick up the phone or I can do a session after my own kids go to bed and when my patients' kids go to bed. And so flexibility and the virtual ability to reach out has been really important to staff. I think that really looking at some national surveys about what's important to behavioral health providers at this point in their lives with COVID, post-COVID, those of us here who have had our lives disrupted by Hurricane Ida as well, find out what people really want, because always it's never been all about the money. You have to pay people fairly, but it's not all about the money.
Absolutely. And I read, there was an article in Fortune a couple of weeks ago, and it was talking about exactly that. And that after a trauma, after a divorce, after a death, after a pause of anything such as what all of us have gone through, people really do reprioritize, and they're making shifts all around, from dangerous jobs away from dangerous jobs that pay lots of money, or towards. But a lot of my patients that have private patients that have been with me for quite some time, I would say over 10 of them have gone back to school to get out of their difficult jobs, and all of the schooling is in mental health. And so the person that asked this question, just wait, provide a good workplace and good incentives outside of money, be flexible and creative. And from what I understand, the LPC, LCSW training programs in particular have had large increase in enrollment.
Jack, can I just follow up a little bit with a comment? You know, some time back when some of the federal organizations were looking at this workforce issue, a big solution that people were coming up with was this emphasis on peer support. And it was very nice to see in Dr. Podesta's presentation that there was almost like an emergence of some peer support networks that came around COVID. But a question I have for the panel is, you know, one of the big sort of thrusts that was going on before COVID was almost this push, not just for peer support, but for a broader recovery orientation. And so, you know, part of what I really am asking the panelists is, what has happened to that recovery orientation under COVID? Because a lot of the design and what people have done has really been sort of, it sounds like what people have done almost in an ad hoc sort of like dike, putting a finger in the dike kind of process by administrators and providers. And so what has happened to recovery orientation, peer support services, and almost like, where is the voice of the consumer and the family member in the definition of what you're all talking about? Because it seems like it's got a little lost, but that's just maybe my impression.
Yeah, I'll take a stab. I don't think it's gone away, Vijay. I think it's still there. I think throughout the pandemic, if you look at how peers supported each other through formal peer organizations or informal peer networks, I think that peer support mechanism is still very, very strong. I think it needs to be built up, and there needs to be more capacity and some more wind put in its sails in systems to validate that out there. But I do think it's very, very real. I also think we're seeing it very much right now in some of the national conversations on strengthening crisis response services. I think you're seeing a strong consumer voice in trying to make sure that, you know, when crisis services are needed, they're led by behavioral health, not by law enforcement. And I think consumers have a front and center voice there for sure. So I'll let others.
I would like to, I'd like to also note that we have all of us experts here presenting to an audience of high-level experts that control a lot of organizations and have a lot of reach. We don't have a patient on here. We don't have a patient or a family member's voice on here. And I think so frequently we miss out on that. And I think it would be lovely and helpful to have a patient that could also be a social worker, a patient that could also be an MD, whatever, but someone who speaks from the patient perspective as a patient or a family member to have that voice.
Yeah, just to add, you know, in the couple of sessions we've had people like that, and will be having a patient that doesn't have.
I'm gonna, if it's okay, I'm gonna move on. There's actually a question for Becky from Mary Smith, who's also on our board. She asked, was there any outreach to consumers to evaluate their perception with regard to the effectiveness of treatment, given the reality of providing treatment within the constraints of the pandemic?
That's a fantastic question. And I'm sure that there are formal studies out there that are being done, and states are required to collect some information on consumer perception of things. But anecdotally, on the calls that I was on, where we were asking consumers directly, how are you doing? Do you feel supported? Do you feel like your treatment is effective? Without exception, everybody we spoke with, all of the consumers said that they felt supported, that they felt heard, that they felt that the team was going out of their way to do anything they could to make them feel comfortable and safe. And so anecdotally anyway, everybody seemed really happy, and they liked seeing the adaptations that their treatment providers were making on their behalf. They liked to see that people were sitting in a car and talking to them on the phone. They felt important. They felt seen and heard and valued in a way that they hadn't before. So it was pretty fantastic.
Was one way to take a stab at the isolation that they would have otherwise been feeling.
Exactly.
So I have a question. It's a double question for Dr. Podesta here. It said, completing an assessment intake with a client can be traumatizing because the questions require the individual to relive certain trauma in order to respond to the questions. What are some tips to minimize this trauma?
I wonder if Kevin could field that one. I think starting before, I will comment on it, but I think Kevin might be able to field that a little bit better. I try and just establish, I don't do that sort of admission. And so I don't have to ask those questions because I'm doing a psychiatric evaluation where it can take as long or as little as I like. So I don't have to, I'm not restricted to that sort of questioning. Kevin?
Dan, can you repeat the question for me?
Yeah, it was, the question was, when you're doing an intake on a patient and you ask a lot of questions of the patient to discuss what their past is, that can be traumatizing in and of itself. So what are some of the tips you would give someone who has to do that type of assessment on a person?
Yeah, and I will qualify this too. I have not done clinical work in a while. And so I do think, that from a trauma-informed approach, there are approaches and interview techniques that are, if you come into it with that background and training, you should be able to navigate those types of questions in an interview or an intake assessment. Maybe also I would just address it, from a systems level, to the extent that we are using technology and integrated healthcare records to the extent that they exist, and to the extent that we can minimize redundancy and questioning of people on intake assessments across different types of providers, I think can also go a long way in being sensitive to trauma that a person may have experienced.
Okay, Dr. Podesta, this is a fun one. Everybody's going to want to know the answer to this one. What are some reasons you may discharge a client from MAT?
Well, I never fire a patient, and I never take people off of MAT unless they want to be off of MAT, and we discuss it with family members. We discuss it every visit, every month, every 3 months. We have an opportunity to shift from, let's say, an oral buprenorphine over to the injectable buprenorphine, or transition from buprenorphine to Vivitrol. So I never take people off MAT or fire people unless there's a reason. And the reasons are, if someone's violent towards me or my staff, then they're not invited back, which has happened. If someone is completely non-adherent, it's like they miss all of their appointments and they can't keep coming, or something happens and they're just continuously non-adherent with therapy, with all of the other tools, then I'm not helping them and they're not helping themselves. And so I refer them to a higher level of care because they need more, not less. And then of course there are some, other disease states that would be certain medications don't go well with MAT, and so it's metabolized through the liver at one particular location as CYP3A4. And if there are medications that are required for a new cancer diagnosis or a new something else that would be medically advisable to stop the MAT, then we would do so, and we would shift to another solution.
I think this question really gets to the whole issue of harm reduction. And I think that that's worth saying a few words about, because we assume that everybody at this point understands and believes in it. But that's because we're a special group of people.
Right. So I think you're right. And I think that if someone's positive for cannabis, positive for heroin, every single visit, and they're still alive and they're seeing me and they're taking their buprenorphine. If someone is selling their buprenorphine and I find out, then let's just pivot. Let's switch them to another product. Let's put them on Bunavail. It has less of a street value. Patients don't love it, but it's what it is. Let's put them on the injectable. Let's reduce the risk of diversion by reducing the risk of diversion, not by stopping their treatment. When someone has a disease and their disease fails treatment, then just like a cancer fails treatment, then the treater has to be harder and more thoughtful and more creative to help the disease, to help the patient. And so, the patient's not failing, the treatment's failing the patient. And so then we have to be smart and creative and use other tools.
That is a beautiful answer. Thank you.
Yeah.
Have a question from Scott from Baton Rouge. Hey, Scott. It says, I'm curious about MAT options to address other addictions, such as stimulant use, as you discussed earlier. Can you elaborate on any developments in MAT for other addictions than opioids?
Sadly, no. So the ADAPT study was great. It's an actual, like I said, a NIDA-funded study that shows that methamphetamine can be helped. Methamphetamine craving and chronic use can be helped with a combination of extended release naltrexone and bupropion or Wellbutrin. Great news, doesn't help that much though. I have in my book Hooked, I have lots of information on different mechanisms to treat all different types of drug use because of the dopamine reward cycle, how each drug affects each kind of part of the brain and each set of receptors, and how we can augment those. There are not new medications at this moment coming out for these diseases. We use a lot of them off label, and this isn't a CME, it's a CEU, so I'm allowed to talk about it off label, but if it were a CME, I would have a little bit of risk. So we can talk about things like baclofen plus naltrexone plus Deplin, for example, for alcohol use disorder. And it's just really individualized as to who responds to what, but those are some great tools that I use. Topiramate is an anti-epileptic that can be useful for alcohol use disorder. Also, we have a couple of studies that gave mild evidence for topiramate for methamphetamine and cocaine use disorder. But there is a push by NIH to there's funding for an opioid vaccine, believe it or not. And so that's really interesting. And what that would do would make it so that you had, if you, let's say, took fentanyl, you would already have immunoreceptors to go attack the fentanyl that comes in, just like if you took, if you got exposed to COVID, you would have immunomodulators to go attack COVID so it didn't attack your cells. So there's a handful of people working on that, and some are closer than others. And then these digital therapeutics are truly a wonderful thing. It's FDA approved for all addiction. It's by Pear Therapeutics, Reset and Reset O. It has to be prescribed, but it can help. It's augmenting therapy. It's not in place of therapy, but it can be a really great tool for anyone in a treatment setting. If you have a prescriber open to prescribing it, getting the therapist to onboard the patient. Well, the drug company or the pharmaceutical company onboards the patient, but getting a therapist to review it with the patient, it can just help elevate by a pretty decent percentage patients' outcomes. So I hope that helps. I hate that it's a non-answer, but it is what we have.
But another question from Brian, and he was saying, now that in many states marijuana has been legalized, are we seeing fewer contaminated with additives like fentanyl, or is it just the same as it was when it was a street drug?
Well, legal doesn't mean legal from a dispensary is one thing, and those are regulated and those are tested, and those tend to not have the additives in it. But you know, and then for Louisiana, we have medicalized marijuana by a physician making a recommendation, and then the recommendation goes to the pharmacy. So those come from pharmacies, and there's the Louisiana marijuana availability from those pharmacies is state regulated. And so, yeah, so they're not quite as rigorously regulated and monitored as FDA would, but they're more similar to getting from a pharmacy. Well, in Louisiana, they're getting from a pharmacy, but like in California and Colorado, where you get it from a dispensary, that's more available. But street stuff is gonna have, if you get it from the street, it's gonna have the likelihood of having fentanyl in it. So when I'm talking to my patients, frankly, about this, I talk about the risk of getting, you know, I have some patients that do have their availability to get the pharmaceutical grade through a prescription. And, but they're like, well, I have it. So my employer, if they test me, then I'm positive, then I won't get fired because I have a prescription. But it's cheaper if I get it from the street. And so I do the education about that, and I do drug testing, even though I know that they're taking marijuana. I do drug testing and fentanyl testing just to see, and I have had a handful that have had fentanyl in it. Not many though, but still, yeah, it's definitely, when it's regulated, it has, we have more control and we have a cleaner product.
And we've seen that out in Colorado as well. I've served on the Retail Marijuana Public Health Advisory Committee for years, and we've seen a shift. And as we saw that shift, conversations with with staff from the DEA have said that the drug cartels have shifted and they've diversified and are pushing different substances on the street and leaving the marijuana alone because it's so available from dispensaries that it's not worth their effort anymore, and they're focusing in other directions. So at least out here, we're seeing a change.
Becky, I wanted to ask you if you have surmised at all why there is a reported increase in mental health diagnoses among 18 to 25-year-old and 26 to 49 prior to the pandemic. I mean, I guess this would just be a guess that all of us would have to make. There's so many factors, but is there something going on with the training of clinicians that are maybe diagnosing more, or maybe less stigma, that more people are going and seeing folks?
That's my guess, is that we're seeing more people going into treatment and getting diagnosed. We're paying more attention to some of the first episode psychosis work and recognizing that early treatment leads to better outcomes. So people are more willing to get tested to go in for those batteries of assessments. So that's my guess, but it is just a guess.
Kevin, come on, let's hear your ideas.
Yeah, I tell you, you know, prior to the pandemic, I just feel like there was a whole bunch of political, psychological stress on the company and on the country. And
well, it was trying to be run as
their own judgments there about sort of the impact on sort of particularly our youth and sort of what they've seen, how they've seen us adults act in the last several years. So
Dr. Podesta, you want to?
I mean, I think that the strife in the country and I think just an elevation in all of our just mental capacity between multitasking, social media, devices, you know, I think that it's just tasking everybody so much. And many of my professional patients that are professionals, many of my peers, everyone's just been tapped out even before the pandemic. And so I think that might reflect in the data. And then of course, the rest of the data speaks for itself beyond that.
And just to add, I think there may also be methodological issues. You know, I think some of the ways that people are coming up with the estimates are also sometimes shifting. And so I think that could be also a partial explanation.
All right, well, we are at 3:15 and I could continue asking questions, but I think that would bore everyone. So I'll just ask one more time with the participants, or if the panelists would like to ask one another a question before we end. Oh, boy. Okay.
I just wanted to come back to one comment that Vijay had made earlier when he talked about the peer supports and recovery, and where's recovery and sort of in the field. And I do think it's important for us to take stock on recovery and look back at what happened over the pandemic. We didn't talk much about resilience, I think, in the session today. And there's probably a heck of a lot of resilience that we saw in people with mental illness and substance use disorders. And, having sort of been in the seat of running a large system and trying to make changes, they're hard and they take time. And we were able to make some pretty significant changes in a short period of time during the pandemic. And I think if you sort of look at that and look at the resilience factor, it should lead us going forward in terms of the types of services, level of supports that people need and want going forward. And so, part of it is, let's build upon what we were doing well. Let's build upon the resilience of people with serious mental illness and substance use disorders. And let's not revert back to some of the things that weren't necessarily producing great outcomes for people, and try to sort of take this as a moment of opportunity to sort of, take a next step in the behavioral health field. We always talk about the evolution of behavioral health services in decades in the behavioral health field. And this is an opportunity where we were able to shift many things in a very short period of time. And it created a window of opportunity for us to build upon that. So I would leave it at that.
So Kevin, just building on what you were just saying, one of the things that happened during this whole pandemic was that in some ways, a lot of the issues related to mental health became not just specialized issues for people with serious mental illness or people with substance use disorders. It became a more general population kind of issue where people were going through anxiety issues, depression. For the elderly, there were all kinds of issues that were sort of emerging because of, a sense of loneliness and isolation. And to me, it seems to me that there's an opportunity that at one level could be capitalizing in sort of making this whole area of mental health issues less stigmatized, but at the same time, there's a kind of tension between the general population approach versus the serious mental illness approach. And it seems to me that in some ways, isn't there an opportunity here to capitalize on this perception that now seems to be pretty general, and you see a lot of coverage in the media about these issues as sort of like a corollary or a parallel to what's happening with folks that are going through this COVID isolation. And so I don't know, my question really is, there's an opportunity here to make and sort of almost do a quantum jump in the area of mental health. And so I'd love for the panelists to talk about, one, the tension, but two, the opportunity,
I don't work in large systems, but I do see that there is a big opportunity, and I do hope that, and I do think that there's been some improvements with things like Medicaid and approvals of, even someone mentioned on the chat, approvals of peer support for financial coverage for peer support specialists. So that's been something we've been asking for as long as I've been in the field, and we finally have it. So I think that there's, with the money that came down the pipeline for substance especially, but also there's an attention to substance and mental health. We keep calling it a pandemic and a pandemic. We've got news articles every single day that begets money, luckily. Now what we do with it is doing, larger systems and the creative pivots that we've already talked about, and then more. I think I don't have the answers, but I think I feel hopeful.
Thanks.
Yeah, sometimes when we think about disasters, we think about, a hurricane or big fires or flooding or tornadoes or things like that. And those, the effects of those have a psychological impact on a community itself. But with COVID, it impacted us all as a country. And when we think about, the data that talks about the increase in potentially diagnosable mental illnesses, we think about the isolation. We think about even some of our bad habits. We probably all drank a little bit more during COVID. There's a sense of, that we're all in this together, and there's a sense of wanting to sort of re-engage with people, and a sense of wanting to not isolate anymore. And I would love to see, from a public health messaging standpoint, when we sort of get out of the intensity of COVID right now, some messaging and I don't know that I have the answers, but communication out there broadly that we're all aware of the psychological impact on it. We don't have to make it pathological. We don't have to scare people about it, even though the data is out there. But we have to really sort of get to this wellness and well-being type of, I think, conversation, so that everybody can relate to it. And maybe that's sort of my pie in the sky type of hope for this, but there is an opportunity here on it. I just think we have to have some real public health dialogue about that, without making it seem like that the entire country is, now diagnosed with a serious mental illness. And I don't mean to say that flippantly, but we have an opportunity to break down some barriers here and raise awareness for sure.
And take away the stigma of mental illness. I think that's what the key factor, because people feel pathologized and they're scared to seek help, or they're scared to even talk about it. And so I think and what we know is we just have this huge increase in mental illness, or in mental health issues. I'd like to even frame it as not illness, mental health issues. And we have a huge need. And so perhaps we can, as leaders, change the dialogue, change the verbiage, and help with destigmatizing. And then on top of that, have a national public health outreach. I have to tell you, I've been trying to get some public health leaders to help with mental illness and substance for the whole COVID pandemic. And I've heard from many, many leaders, we can't focus on that. We can only focus on COVID. So it's been sorely a very missed opportunity. We had 15 minutes every time someone got their initial and their follow-up shot, and now their booster. We have 15 minutes where that could be used as health education. That could be used as a time that could have been. We've been talking about this for over a year, since the vaccine's been out. That is a perfect place for someone to get access to education, get access to suggestions for, treatment, for breath work, for whatever would suit them, but we missed that opportunity. So I think we need some more integrative thinkers in leadership that are able to do more than one thing at once.
Maybe somebody on the call. Maybe someone on the call will do it.
That's what I'm talking about. That's why I'm talking to you.
No, and this is really hard, because when you think about everything that's on everybody's plate, even if you look at it from a state mental health authority perspective or a county mental health authority perspective, the things that come across their desk on a daily basis are significant. And when you think about all that goes into it, and coordinated strategy across federal, state, and local agencies, and trying to fund those types of things, it's really complicated. So there's an opportunity, but it's not easy. This is an area probably where I would love to see states take a lead on it, but I would also love the federal government to really sort of think about not only crisis services and all those things that are going on right now, but how do we sort of elevate this conversation and get elected officials on board, so we can jump on that. 988, the new national hotline number that's coming in play, is, I think, a national conversation about increasing awareness. If you're struggling with symptoms or a crisis, to call it. It takes it out of the police and criminal side of the world and puts it in the behavioral health side of the world. That's all part of this, and communication strategies can come out of that as well. So.
Well, thank you. Thanks, Jen, for moderating. I think we're arriving at the end. I just want to remind people of a couple of things. One is for people who have who want CEUs, the code word this time, designed by Melanie Norwood, who is our CEU coordinator, is WICHE, W-I-C-H-E -53. So when you send in your CEU evaluation, please include that code word, WICHE -53. Then the other thing I want to do is remind everyone when this session is over, what should come on your screen is a URL link to the survey for this session. I want to thank Jan. I want to thank all the speakers. I have to say that I thought that the discussion from my perspective was very informative, very rich, and both the presentations and the discussion. And I hope all the participants thought so as well. And so I don't know, Jan, if you've got some last comments you'd like to make.
No, I mean, it felt like 2.5 hours was going to take a long time, but I agree with you. I thought the discussion was great. Want to thank you all for staying on with it, but also remind you that that's what makes National Dialogue so different, is that we have always kept it a pretty small in-person meeting so that there could be discussion with people who gave presentations. And, that's where ingenuity and creativity come from. And that's kind of what Dr. Podesta was saying is that, oftentimes the structures and institutions we work in don't allow us to be creative, but that's exactly what we really need to do. Yeah. Kevin talked about the 988 number. I think it's wonderful. There's discussions about crisis. But the only thing is, if we only talk about crisis, we'll only get people when they get into a crisis. So I love ideas of, being innovative wherever you are, even if it's just a small clinic or a private practice. And then sometimes we have to grow it from the ground up, and we can't leave our institutions to catch up with us because oftentimes they're a decade behind what's really going on in the community because they're so big. But just say thank you again. This was a really nice session. Appreciate all of you.
Thank you all.
Thank you.